So welcome everybody. This is the first seminar of the series of this academic year for the Institute for Health Policy and Organisation. Just a really quick introduction to the Institute for those of you who don't know. We're a cross-faculty institute, a research institute which brings together researchers from different departments who do organisational policy related research in health. We've got three overarching aims, which are to make policy research more visible internally within the university, and to support grant capture and support colleagues working together across faculties, to provide an external face for health policy and organisation research in the university so that people outside can find us, and so that to make the international links that I think in the past maybe we've not been quite so good at. And finally, to build capacity in health organisation and research. And so the seminar series is really an important part of all of that, because it's important for raising our visibility internally, but it's also important for making our external link. And today, having Michael here presenting from Australia ticks a number of those boxes. It brings us together internally, but it also is making these nice international links with colleagues who do similar types of research elsewhere. So we're very grateful to Michael for coming and presenting for us today. I first met Michael a long time ago when he was working in London. I'm not quite sure, probably 10?
Maybe 2012, 2013.
Yeah, something like that. So before Michael did his PhD, so he was a GP working in London at the time, and he worked with us, with our colleagues in the London School of Hygiene and Tropical Medicine. Since then, he's gone back to Australia, done his PhD, and he now describes himself as a GP and health economist, which I think is a great description. I don't think there aren't many of those around, so that's quite a good thing to have on your CV. Michael's a practicing GP, but also works at the Sydney University of Technology Centre for Health Economic Research and Evaluation. Is that right? Chair.
Chair for short. Yeah.
Chair for short. And his focus is on the impact of current health policy on quality and performance in primary care. So obviously core areas of interest for many of us in the Institute and also in our in the Centre for Primary Care. So we did intend to have a visit in person. Michael was due to join us because he was going to go to the Society for Academic Primary Care and come and have a nice visit with us. So I'm afraid this virtual visit is having to stand in for that. So thanks very much, Michael, and over to you.
Thanks, Kath. Hopefully I can make that visit next year. Hello, everyone. It's nice to see a few familiar names and faces. I'm just going to try and share my screen, and we'll look. So first, I'd just like to thank Laura and Lindsay for organising today, and thank you, Kath, for the kind introduction. It's great to see you today. The first thing I'd like to do is just sort of acknowledge the traditional owners of the land on which I'm meeting, which is something we often do in Australia, just to recognise the Indigenous Australians. And I'm talking to you from Gadigal land, and the Gadigal people were the traditional owners of the area around Sydney Harbour, and so were the first people who encountered the first fleet when they landed.
Michael,
and
sorry, Michael, to interrupt.
Yep.
We can't see your screen.
Okay, it took about 30 seconds last time. Does it say that I'm sharing the screen?
No.
Okay. Oh. Okay. Let's get that. Okay. I think that's better.
Yeah.
Great. And look, my research interest is about improving the efficiency and the effectiveness of general practice, both general practice care, but also the role of general practice within the health system, and understanding how incentives drive behaviour of patients and providers. There we go. Now, what I'd like to do today is firstly give you an overview of the Australian health system and its challenges, focusing on primary care and general practice, which is where I come from. And then I'll describe some of the research I've been working on, which takes advantage of some of the features of the Australian health system to answer what we thought were interesting research questions. And then I'll finish with some discussion about future reform, which has been accelerated by the COVID pandemic. And if we get time, just talk about Australia's COVID experience. Sort of to start, Kat's alluded to some of it, but just a bit of personal context. So I grew up on the Gold Coast in Queensland. I did my GP training there. I then came to the UK for 4 years. I did my master's in public health and health economics at LSHTM. And that sort of started my interest coming back into health economics. I worked as a GP in the NHS and in a private practice in the city. And since coming back to Australia, I've completed a PhD in health economics. And my PhD thesis was investigating the value of continuity of care in general practice. So I'm going to talk a little bit about that today. And back in Australia, I still call people, I tell them I'm a portfolio GP, which no one in Australia has heard, but they all love the term. So thank you for letting me take that back. I thought I'd give you the take-home messages up front that, look, from my experiences in working in both countries, I think we've got similar population pressures and health system challenges, but we've got vastly different structures and fundings of our health systems, and particularly notably for general practice. I find that if you understand the incentives within the health system, you can more clearly understand and predict how patients and providers respond. And our challenge at the moment is our health reform agenda needs to balance multiple priorities, so including access, continuity of care, quality, and cost. But importantly, we need to design incentives that align with the desired behaviours. I just thought I'd give you a bit of an overview, a couple of slides about Australian population demographics. So until this year, Australia's population has been growing around 2% a year, about 25 million people with a common birth and increasing migration. And like the UK, we have an ageing population. So the median age of the Australian population's increased by about 3 years over the last couple of decades. And we have a high proportion of people living who are aged over 65. That's about 15% in Australia. The chronic disease is the main challenge that we're facing. So we've got an increasing proportion of Australians living with multiple chronic diseases. So as you can see from these statistics from our local Australia's Statistical Bureau, about half of Australians have at least one of eight common chronic conditions, and nearly half of people over 45 have 2 or more of these conditions. So they're causing close to 90% of the deaths, over 1/3 of hospitalisations, and over 50% of the burden of disease. So that's the big challenge that we're facing in our population. But there are some other challenges too. So we have increasing income and increasing expectations of care. So patients are expecting more care in our system, and also increasing costs of new technologies such as drugs. We also have a rapidly growing health professional workforce. So the number of GPs in Australia has grown by over 50% in the last 10 years. Australia decided to increase the medical supply about 20 years for fear that we didn't have enough medical practitioners. So we now have a large output of doctors. We have also a very large output of general practitioners. And then we also managed to import a lot of GPs from overseas. The other sort of final challenge we have is we have ongoing inequity. So particularly for our Indigenous Australians, and also for those who are from lower socioeconomic classes. Sorry. So just a bit about the Australian health system. So Australia's got a federated health system. We have a Commonwealth and then 8 states and territories. But the states and territories have responsibility for funding hospitals and also schools. But and then the federal, basically the Commonwealth government has fairly prescriptive things of what it can cover. And one of the things it's supposed to cover is out-of-hospital care. So we basically have 2 health streams that try and work together. And I'll explain this a bit more. Medicare is our universal health scheme. So that came in 1984. And really that was the last major reform of the Australian health system. And it brought together the public hospital health services, which were funded by the states, and link them to subsidised out-of-hospital medical care for all other medical practitioners, including GPs. And that's funded through federal taxation, and there's a hypothecated Medicare levy that we'll contribute to. There is a considerable amount of private healthcare in Australia, and around 40% of Australians have private health insurance, but that insurance is for hospital cover and for attending private hospitals, and is less relevant to a general practice. So you can't insure for your GP visits. So I won't talk more about that. This is just outline, just looking at where the money comes from and where it goes. So on the left pie graph, you can see that 40% of the funding comes from the Australian government. The states and territories bring in 26%, and then smaller amounts from health insurance funds. You will note that there's a significant proportion of funding that comes from private individuals. So that is out-of-pocket costs. And then if we look at the expenditure, you can see nearly 40% of expenditure goes on hospitals. Interestingly, the expenditure on hospitals is more than the money than the states bring in. And so, as well as funding community health, the federal government also shares the funding of hospitals. So that's a shared responsibility. And that has implications for how a lot of health reform rolls out. If you look here, it says 35% of funding goes to primary healthcare. I wish that meant general practice, but it doesn't. Actually, only about 6% of health funding goes to general practice, and the remainder of this is made up of pharmaceutical, like prescription pharmaceuticals, over-the-counter pharmaceuticals, and other allied health providers. So just looking at overall health expenditure, so Australia is getting close to 200 Australian billion dollars a year, and in pounds, that works a bit over £4,000 per person, and that's looking at the OECD estimates that I've seen. The proportion of health expenditure of GDP that we spend on health has been growing gradually over the last decade, but it has stabilised since about 2018, and it's just over 10%. And if you look at that picture on the right, you can see Australia's just under the UK as a percentage of GDP, but we do spend more than the UK per capita. And there are some ONS figures that I found that just suggest that Australia, we're about £3,600. In the UK, it's about £2,900. I'm assuming many of you have seen this. So this is the Commonwealth Fund's International Health Comparison, which compares 11 health systems on a number of criteria: care processes, access, efficiency, equity, and outcomes. And I've just highlighted Australia and UK, and you can see that we're the gold and silver medalists of this. But despite that, you can see, yeah, so UK is first, and actually the next Commonwealth Fund comparison's coming out in a couple of weeks. So we'll be interested to see how things have, if anything has changed. But you can see the main area which Australia falls down is in equity. And as I mentioned, although the healthcare is good when you can get it, access and your ability to fund it is variable. So just moving on to general practice. So I'm just going to outline some of the features, and I might sound this a bit provocative, but it's more to highlight the differences fairly clearly. So I think the first thing to say is we have no enrolment and there is no practice registration. So patients can attend multiple practices and there's no restriction in that. We have near universal use of electronic health records, but they are contained within a practice, and there's very little sharing of information between practices. And I would say, yes, minimal communication between primary care and secondary care. There's a lot of intent to make that happen, but there's not a lot there. GPs and practices are paid by fee for service. So every time a patient comes in, GP delivers a service and the GP gets paid. There's no restrictions on what the GP charges for any service. But in Australian Medicare, it has a list of fees that it suggests, and a GP can either accept that fee or charge a private fee. And if the GP and the patient is given a rebate, which is the amount of the subsidy that goes towards that cost. In this system, there are a few payments for non-face-to-face care. Basically, as a GP, I spend my day sitting in front of patients virtually the whole day, because I get paid when I'm sitting in front of patients, whereas I don't get paid while I'm not seeing patients. And so that creates certain behaviours as well. And the other issue with this fee-for-service system is that it is essentially only rewards GPs, and there's minimal opportunity to delegate work. Just interesting, most GPs are then paid as a percentage of their billings. So they then take a part of the total billings that they've achieved, and often they're given a percentage of sort of somewhere between 50 and 70% of their billings. So that fee-for-service system makes up about 90% of general practice funding. There is patient contributions, so out-of-pocket costs, which I'll discuss. And we also have another program which is called the Practice Incentives Program. So it's an infrastructure payment to practices based on the practice size. We've had small experiments with using GP quality incentives within this Practice Incentives Program, but they ceased in 2019. So what you can probably see from all of the way this is funded, the incentives within the fee-for-service system are for GPs and practices to increase output, to increase our activity. We're also incentivized to lead the care and not to delegate. And we're sort of incentivizes to provide more healthcare, not necessarily more health. And so there's fewer incentives for prevention, for non-face-to-face care, or for us to treat high needs populations. No enrolment means that people can attend multiple practices, and that potentially has impact on continuity and quality. And then this failure to communicate records outside of the practice has issues for fragmentation of care. And as I mentioned, out-of-pocket costs are a feature. But it's not all that bad. I'll give you some figures about what's happening. So within our health system, general practice is the most accessed part of the system. In any given year, more than 80% of patients see a GP. GP visits are increasing. So the number of GP visits per year has increased from sort of 5 to just over 6 in the last decade. And around 12% of people have had more than 12 visits. But there is inequity of access in rural areas and also for Indigenous Australians. Just in terms of patients' experience, despite this system, this is like Australia has an annual patient experience survey asking patients, how often did you feel your doctor listened carefully, showed respect for you, spent enough time for you? And around 75% of patients say always for all of those, and only a small proportion who say sometimes, rarely, or never. And finally, cost. I mentioned that GPs can charge basically what they want, but in reality, most GP visits are delivered without cost to the patient. So, and I think part of this is because of the flexibility where patients can migrate to any different practice, that potentially creates some competition amongst GPs to keep their prices down, particularly in metropolitan areas. So the choice is that you can either accept the Medicare fee, which the Medicare rebate for a standard consultation is about $38, so it's about £20, and you can accept that as full payment for the fee, or you can charge patient, say, £40, and then the patient will then get the £20 as a subsidy, but they would then pay you an out-of-pocket of £20. So there's only a small percentage of people who are getting those out-of-pocket costs, so about 14%, but that cost is rising. And so that's what I'm showing on the graph on the right here. So the rebates that Medicare provides have been frozen for 4 years, and they were recently unfrozen in 2019. And over that time, basically the average out-of-pocket cost has increased to close to $40, and it's sort of at the point where it's almost crossing what the Medicare rebate is. Now, any questions so far? I hope that's clear.
Yeah,
if not, I'll just... Yeah.
Sounds like that was perfectly clear.
Okay, great. I'll just sort of move on. So the next bit, what I wanted to do was just talk, given that framework of basically understanding how the system works, I'm now just going to run through a couple of research pieces that we've done trying to understand patient and general practice behaviour in the system. So first of all, we tried to look at if patients can go and see multiple GPs and go to multiple locations, do they? And if so, what are the characteristics of these multiple practice users? So what we did for this was we had a panel survey of nearly 2,500 Australians, and we asked their experiences about general practice care, socio-demographics and preferences for seeing the same GP or the same practice. You can see the variables on the right there. A concession card's an indicator of lower socioeconomic status. Regular GP was asking people, do you usually see the same GP? Do you usually attend the same practice? Have you attended more than one practice in the previous year? And the results of interest for us were understanding, do you usually go to the same practice every time you see the same GP? So nearly 90% of people, over 80% of respondents said that they usually go to the same GP within that practice. But despite those high levels of what we might call loyalty or intended continuity, over a quarter of the respondents said they'd been to more than one practice in the previous year. So we thought that was quite interesting. And we then just ran some logistic regression models with the outcome variable being multiple practice attendance, and then with all of our explanatory variables. And I'm just going to show you one forest plot of the results. So just looking at this forest plot, so the red line down the middle is unity. If a variable is to the left of that, that suggests that it's associated with being a single practice user. If it's on the right, then the variable is associated with being a multiple practice user. So, and then the long lines are obviously the confidence intervals. So if it doesn't cross those, it's significant at a p less than 0.05. So firstly, we found that older patients preferred going to a single practice, and we weren't surprised by that. And there was a statistically significant trend for that through every age decade. There were no differences in gender, but we were interested to see that people who had a higher educational status higher educational attainment were more likely to be multiple practice attenders. And we thought potentially for these people, they placed less reliance on the continuity of care or the need to have a regular doctor to potentially act as their advocate, and they feel more comfortable in making their own health decisions. People who have concession card holders are potentially were more likely to only go to one practice, and potentially that's because that once they found a practice that bulk billed them or didn't charge them an out-of-pocket cost, they might be more keen to stay at that practice rather than move around. The results related to health were fairly inconsistent. I mean, this is fairly obvious, but the people who said that they usually attend the same practice were significantly only went to one practice. But what we did find interesting is that if you ask even people who said they'd been to multiple practices, they were just as likely to have a preferred GP as single practice attenders. So for us, this meant that, and this fits in with a lot of behaviour that we see, you'll talk to patients and they'll say, oh yes, I've got a regular GP, but when I can't get into them, I'll go to someone else, or I'll pay to go to my regular GP, but if I got something simple, I'll go and see another practice. There was practice level variables were less important. We thought that if a practice had lots of doctors in it, then patients might not go to other practices because there was more capacity. There's a trend for that, but that wasn't significant. And patients who were patients who had no out-of-pocket costs at their last appointment were more likely to be multiple practice attenders, which that suggested to us that potentially patients are shopping around to avoid costs. And then the multiple practice users also used other services. So our learnings from that was that multiple general practice use is common in Australia, and this was a novel finding. And given that there's no process to notify multiple practice use or to share patient information, this potentially has implications on informational continuity, and then more broadly on the quality of care and healthcare costs. So just a quick sort of background onto continuity of care, which was, as I mentioned, this was what my PhD was about. And so refers to receipt of care from one provider beyond a single acute illness, and considers both the benefits of the long-term relationship, which we call relational continuity of care, as well as the sharing of information. It's a key feature of primary care, according to Barbara Starfield, and one of the core components of high-performing primary healthcare systems. And there's lots of evidence showing an association between continuity of primary care, particularly general practice care, and positive health outcomes. And for a number of years, and that's still coming. And what we wanted to understand in Australia, though, is that given that patients can and do attend multiple practices, how does that impact on continuity of care and potentially the quality of care? And we also thought that what the Australian context gives us what we could do in the Australian context is because some people went to the same GP, but some went to the same practice and some went to neither, we might be able to differentiate between the potential benefits of shared information, such as informational continuity, with those of a strong doctor-patient relationship. What we did was investigate the association between continuity of care and cancer screening. We chose cancer screening for two reasons. One, because there's less immediate benefit for patients in screening. So if you're going to have a screening test, you're unaware of what the value of that screening might be. And so we thought that that was a better indicator of potentially the value of a strong relationship, in that might have a greater influence on whether you screen. The secondary reason for choosing cervical screening or Pap testing is one of our challenges in Australia is we have very little clinical data. So practices collect their data internally, but we have very rudimentary systems of data sharing. Now they are emerging, but at this point they still weren't there. And cervical screening is one of the few tests that's recorded in administrative data and the statistics in order to pay pathologists. So for this analysis, we used a large longitudinal study of Australian data called the Australian Longitudinal Study of Women's Health. And it's been going since 1996, and there's 4 age cohorts of women between 12 and 15,000 in each cohort. And in 2 of those age cohorts, they're surveyed about their behaviour and seeing the same GP and seeing the same practice. So one cohort was born in 1945 and one cohort was 1973. And this survey data is also linked to the Medicare data, and that allowed us to estimate when women had their Pap tests. And let me say that all of this data analysis was done at a time when women were recommended consistently to have a Pap test every 2 years. If I just sort of explain this framework of continuity, so what we thought was, if you look at people on the left, so people who get all their care from one provider, because there's very little information sharing between practices, they would get the benefit of one provider, plus also the benefit of information from that provider. In the middle, you have site continuity, so these people were getting care from multiple GPs within a practice, but they would still get some benefit related to the shared information. And then you've got the multiple practice attenders on the right. And so if there is some therapeutic benefit from having continuity of care, we expect to see some differences between these 3 groups. So that's just outlining the different variables we used. We had an extensive range of demographics, income, concession card status, and also asked women how easy it was for them to have a Pap test, how many GPs in their practice, could they get bulk billing, could they see a female GP? And we ran lots of models, but we had 2 main analyses. One was modelling the likelihood of women having a Pap test in the previous 27 months, which is basically the time before a Pap register would send someone a letter telling them they're overdue. And we did a panel data analysis. Random effects was our preferred model. And we then ran a subgroup analysis, which was, we looked at the women who had become overdue for a test, and then we looked at their time to retest once they were overdue. And we used 12 years of data, and we analysed both the full sample and then both cohorts separately. And I'll just show you quickly. So this is sort of the interesting. So these are the 2 different age cohorts. If you look at the continuity, the women who said they always saw the same GP, it was around 40% of the total sample, but it was higher in the older cohort of women. And conversely, multiple practice attenders tended to be in the younger age group. And then site continuity was fairly consistent. So patients, the similar number of women in each age cohort attended the same practice all the time. And then about 50% of women had a PAP test in the last 27 months. This is just what this graph's showing is just the proportion of women who had a PAP test in each year according to their continuity sample. So if you look at the dark blue line, that's the women with personal continuity or GP continuity of care. The thick dotted line is site continuity, and then the one down the bottom is the reduced continuity or the multiple practice attenders. And I think you can see that the multiple practice attenders throughout the years were less likely to have had a PAP test recorded, and that site and personal continuity are higher, and that of those site continuity of care is highest through most of the time. These are just the results, and what we found was that compared with women attending multiple practices, women with personal continuity had an increased odds of having a PAP test in the last 27 months of 1.15, and the results were the same for site continuity. So we also 1.15, but when you look at the different birth cohorts, you can see for the older women, only personal continuity of care has some impact. So potentially, we thought it may be that the relationship has some impact in that cohort, or it's something about the women who choose to still see the same GP at that point. But interestingly, we found the results were of greater significance for younger women. And that we thought that was also interesting because a lot of discussions about continuity of care talk about its value being for older people and with chronic and complex conditions. And so that was a surprising result for us. What we did, we then also had this subgroup analysis of the women who were overdue testing, and then women with site continuity of care tested nearly 2 months earlier. So they basically went and had another test nearly 2 months earlier than people without either continuity of care. And women with personal continuity of care also went back about 1.75 months earlier. So that to us suggested that there was an effective continuity of care in increasing PAP testing, and it did show some therapeutic effect of continuity of care, and it was statistically significant, but we thought of doubtful clinical significance if having the PAP test 2 months, if only having the PAP months 2 months earlier was the finding. As I mentioned, we thought limiting continuity of care to older people or those with chronic conditions might limit the benefits. And we've suggested that we need incentives to encourage continuity of care in Australia at both levels, to encourage patients and GPs, but importantly, they shouldn't override other positive incentives within the Australian health system, such as those at the moment which encourage access and high satisfaction. What I want to do now is just have a little talk about the Australian health reform agenda. Now, I remember in the UK and Australia is not dissimilar, that about every 2 years we get a grand plan for health reform that comes out, and then another one soon after. One of the challenges for Australia is that a lot of the reforms which talk about strengthening general practice within a health system and shifting care out of the hospitals, saving money on potentially preventable hospitalisations and saving money on emergency departments, is difficult to sell in our federated system, because we would say as a GP, or say working with the RACGP, we need to put more money into general practice and you'll save all these downstream costs. But the Commonwealth sees all the downstream savings being given to the states when they have to put in the initial investment. So they're less keen. So it's one of the challenges that we have in reform. But having said that, there's been attempts to try and move Australia away from nearly 100% reliance on fee-for-service for over 20 years. Our last couple of reforms has been one based around the patient-centred medical home, which is called the healthcare home. And then we've also been trying to shift the focus of the health system away from the hospital setting. And I'll talk quickly about the long-term national health plan and the RACGP vision, and then about our trial in voluntary enrolment. So back in 2015, we had a primary healthcare advisory group which recommended very sensible things that we needed to target services to need, encourage patient involvement. We need to encourage flexible care. We need to better coordinated care, needed to restructure payments, needed better data, and we needed to evaluate the reforms. And what at the center of this was this idea of establishing what they call the healthcare home, which is similar to the American, well, the patient-centered medical home model, which basically is a chronic disease, very good for patients with chronic disease. It has a GP-led team working together, not just a GP-driven team driven by fee-for-service. So in the healthcare home rollout, it was for patients with chronic and complex conditions. Patients would agree to enroll with the practice and have a chosen GP. So this is the first time that we were trialing voluntary enrolment in Australia. Patients would be risk stratified, and based on that, there'd then be a bundled payment for their chronic disease management of between sort of $600 to $1,800 a year, which is also like the first attempt at introducing blended payments or a bundle of payment into general practice. And with the idea of this being that it would increase access for non-face-to-face care, it would allow GPs to pool funding and work out what are the needs of their population. And so work towards a population health approach rather than just dealing with one patient at a time. Now, the results of this, it's ongoing. So this trial started in 2018. It was unfortunately had less than, it was quite unsuccessful in its early enrollment. And so originally it was planned that there'd be 50,000 patients enrolled around Australia, but the final patients at the end of the enrollment period was under 12,000 patients. So there is an evaluation of clinical outcomes and costs that's ongoing. And as I said, that's a positive thing because a lot of our reform doesn't get evaluated. And it will be interesting to see what happens. But the early findings suggest that people didn't know what they were supposed to do with the pooled funding. We'd never had this sort of blended funding before, and there was not really any direction on what you should do with it. We also found that you definitely need a practice leader to drive this change in your practice. And there was criticism that the whole program didn't really invest in any change systems. It basically said, here you go, we're doing this and we're off. The RACGPs put forward a vision for general practice and a sustainable health system. So this has just come out last year. And also very sensible, based on patient-centered medical home, focus on care being delivered in the community, embedding the role of GPs as stewards and central to patient care, but recognising there's the whole system that we need to look at. And it also suggested we needed to have some flexible models of care, but also supported voluntary enrolment to improve continuity of care and to support this flexible care and funding. And once again, this is sort of an alignment of both funding groups and also RACGP to suggest that voluntary enrolment would be worth doing. And so this year, we announced, or actually late last year, nearly $500 million was set aside in the last year's budget to enroll a process for over 70s to enroll. So from July 1 this year, all patients over 70 and all Indigenous Australians over 50 can register with a GP and practice of their choice. Practices would then receive additional quarterly payments on top of the fee-for-service, and patients would have access to additional non-face-to-face services such as telehealth or scripts without appointments, which I know is, you wouldn't believe that that doesn't happen already, but given the fee-for-service model, a lot of that basic care doesn't happen without an appointment in Australia. And so with the idea that this would increase the flexibility of care, move away from fee-for-service, and increase the GP funding, which, as I mentioned, we'd been through this GP rebate freeze, and so Medicare had been frozen for 4 years, and there's increasing concern about the viability of general practice. So that was due to start on July this year, but this happened. COVID hit, and the program has been stopped, and a lot of the reform process has slowed at the moment. So I thought I'd just let you know what has happened with COVID. So Australia's early COVID response, Australia was very fortunate being able to shut all the international borders to flights and ships early on in the pandemic. There was early widespread testing. The government set up 150 GP-led respiratory clinics around the country, which were designed to assess people away from general practices and away from hospitals and get treated, and sort of get completely moved away from existing health services. There was also an ability to close most, well, not close private hospitals, but close them for routine care, and basically they were only available to be used for COVID patients, and the federal government paid those hospitals to stay open without any patients, just in case there was a big surge. And in public hospitals, they stopped all non-urgent care. From a general practice point of view, the most interesting change was in early March, we were offered temporary whole of population MBS funded telehealth, so via telephone and video consultation. I'm going to talk a little bit about this. So before the pandemic, there's been very little funding for non-face-to-face care. The exceptions being for video consultations in rural areas for specialists. And that's particularly been picked up by psychiatrists. So from March this year, basically every GP consultation can be provided by video, and then or telephone if video is not available. And it's remunerated at the same rate as a face-to-face visit. However, it has to be delivered without any out-of-pocket charge. It was initially due to finish in September, but now is due to finish March next year. And I just wanted to show you what the impact of this has been. So this is how it's changed. This is from some colleagues at University of Queensland who analysed the Medicare data since the start of the pandemic. If you look at that purple line up the top, that's looking at the number of face-to-face visits, consultations per month. So it starts at about 10.5 million, sort of going between 10 and 11 million a month. At the start of the pandemic, there was an uptick of grey. And what you'll see is the grey is telehealth consults, but the grey is actually telephone consults. So nearly 95% of the telehealth consultations are being delivered by the telephone, and only about 5% are being delivered by video. So, and what you can see, the scale's different on the right, but you can see that the average number of telehealth consultations is around 4 million, but there's been a drop in face-to-face visits from over 10 to around 8. So there's been an overall increase of about 2 million consultations per month, but a drop of 2 million of face-to-face. And this differs. I just thought I'd compare that with what happened with mental health consultations. So this is GPs, psychologists. There were around somewhere around 600,000 per month, and very rapidly, once again, scale is different, but there's a fairly high uptake of those consultations, and that there's nearly, if you look at April, there's around 400,000 mental health consultations being delivered by telehealth, and nearly half of them are via video. So sort of the learnings from this are ongoing, but I think the early finding is that GPs have rapidly adapted to this new funding stream if it aligns with current business models, and also if it keeps patients safe. So I think the main challenge, I mean, there's a lot of discussion in Australia about why GPs are using phones, and most of us say because we've got them on our desk. Many GPs haven't had video, and I've worked in practices that still don't have a video camera because we've never used one. And I don't know about you, but there was no ability to buy a video camera when everyone started working from home. So essentially GPs just did what they needed to do, which was use the telephone. But the challenge now is trying to devise a model for this that will be sustainable. So we also found that telehealth's at least a partial substitute for face-to-face care, which was good. It didn't just add on complete services. And that makes sense, that I think for a lot of GPs, there would be efficiencies in being able to provide care over the phone that otherwise would have required a visit. Since it's come out, there have been changes introduced. So originally, any GP could do a telehealth visit on any patient. And now it's been changed so that you have to have had a previous face-to-face visit in order to access telehealth. And the ongoing challenge here is going to understand what's the value of telehealth. So I think originally the value of telehealth was very high, particularly during the pandemic, because it was preventing additional illness, potential hospitalizations that would have occurred if patients contracted COVID-19. But as our case numbers decrease, that value, particularly for the funders, will decrease. So, and potentially for patients, although the GPs, it's a lot of GPs say, well, it's time is time. So I either do it by the telephone, by face-to-face, or by video. So it doesn't really have a different value from a GP point of view. Now, just reflecting on what happens in Australian health reform. So what I've sort of found from these research projects and looking at this reform is that improving access seems to be driving most of the initial reform. And looking at the example of telehealth is that initially there's this desire to improve access to a service, then that service is introduced, then there's concern about it being over too expensive, and then at the third point is trying to understand what the quality of that intervention is. And it would be useful if health reform considered the cost and quality before it introduced these things. Like I've mentioned before, who benefits from savings? So if you introduce something, if the federal government adds a couple of $2 billion to allow GPs to better coordinate care in the community, and there's less hospitalisation, most of that savings then goes to the states, and the federal government is less interested in that. Patients and providers are responding rationally to incentives within the health system, and if we do design them better, we can anticipate that they will respond differently again. Importantly, one of the challenges we have in general practice, and particularly in Australia because of our limited data, is we just don't know what the quality of general practice care is in a lot of settings. So you saw from that Commonwealth Fund that we're really high in health outcomes, but we don't have any evidence to show that if we change the system, this would make it better, or there's little Australian evidence about that. And so the political will to change the system completely isn't that high when the costs aren't that high by international comparisons and the outcomes are pretty good. And then finally, it's just the point that with only about 6% of the health budget going into general practice, sometimes it feels like, where the tail wagging the dog is that, a lot of these savings need to come through and reform needs to come through the acute care setting, and that trying to do it through primary care, sometimes it feels like we're just tinkering around the edges. Now, that's all I want to say. I remember reading what someone said that if you wanted to finish a presentation and seem smart, you should put up an Albert Einstein quote. Now, I don't mean to do the reverse, but I think given that hopefully there's only a couple more weeks of this guy, I thought we'd hear what Donald had to say about healthcare. And nobody knew healthcare could be so complicated. On a happier note, I thought I'd leave you a picture of Bondi Beach, and leave you with that happy thought rather than the last one.
That's brilliant, Michael. Thank you very much, and you've stayed really nicely to time. So I know some of you may not be. We've got another half an hour or so for questions, but I know some of you may need to leave. But and if you do, then obviously just dip out. But yeah, we've now got some time to have some questions and discuss things. So if you've got a question, if you can either put up your hand using the hand thingy, I can see who's putting their hand up, or you could put something in the chat. So please come on with your questions. I've got one to start with, which is, so from a UK perspective, it just seems really weird that people don't register with the GP. And I just, if you had a sort of sense of why that's not.
No, and look, and that I was sort of being a bit provocative in pointing out these glaring differences, and you think, how can that system work? But I think on a day-to-day level is most patients self-select to come to a particular practice and would see me, see us at our practice maybe 90% of the time. But not maybe once a year, they'll go and see someone else for something that they see as a minor complaint because they can get in quicker. And because I charge an out-of-pocket fee, they'll go and see someone else because it's cheaper. So I agree. I think it's awful, you know, that we don't, and we never get notified of that. So if that other person goes to another doctor, I don't know that they've seen them. And COVID sort of highlighted that. So, you know, how I mentioned these COVID testing clinics. So they've been doing tests and they've gotten better, but initially they weren't communicating with GPs that they'd seen patients. And then even worse, the hospital sector has struggled with communicating results to GPs. So you know, my early experience was having patients attend my practice going, you know, I suppose you've heard about it. And I go, no, what? And they go, oh, I've had COVID. I've been in quarantine for 2 weeks. And I go, oh, let me get you a mask. No, so, you know, that's been our experience. Now, thank goodness the levels have been so low, community transmission's been so low that it hasn't been an impact, but it highlights the problems of the fragmentation, and having patients registered with a practice creates a default link. And so I think then there's no excuse for not communicating with the regular GP, which is often what the excuse we get now. People say, oh, we didn't know who the GP was, or they didn't tell us who it was, or we didn't have your address. Whereas, you know, that's to me is one of the bits of enrollment.
Yeah. So Jen's got a hand up.
Hi, Michael. Thank you for that. You covered a lot of really interesting topics, and I'm a GP originally from the US, so came to the UK to do my PhD. So I feel similar to you that I've experienced it on both sides. And yeah, some of what you were describing about Australia reminds me in some ways more of the US and that sort of thing. And I have a lot of questions I could ask, but I'll go to the bit you presented about continuity. I'm a huge fan of continuity, and I've said that in some ways within the US, continuity was surprising to me more preserved than what I've seen in general practice here because of some of the undermining of personal continuity I feel like previous reforms on access have done. But obviously continuity I know is a tricky thing to measure and therefore study, and you've obviously attempted to do this in your research. But I have to say I'm not completely convinced about the causal nature of the better continuity leading to better rates of cervical screening. I feel like from my knowledge of the types of people who tend to have disjointed continuity in their care, they're often people with chaotic lives for various reasons. They might be more likely to be the ones who need an appointment at the last minute and theirs isn't available, so they go to either another doctor or another place for various reasons. And it's almost a sign of a certain behavior pattern in a person, but not necessarily that the system is helping that, you know, service to be taken up by those people. But and also around excluding the people who didn't have any GP visits in the previous, you know, during this time. I was wondering the effect on that and the decision around that. Yeah,
Look, I take your point, and I think that was one of the things we were trying to look at. Is there's lots of research that says continuity is associated with better outcomes. Now, potentially people who are healthier, wealthier, wiser are more likely to go to the same GP because they can. You know, they've got more time to get an appointment where they need it. Whereas people who have to go to work, might have work in different locations, can't afford to pay an out-of-pocket cost, they might go to multiple practices. So I agree. I think that's something that we wanted to try and unpick. And that's what we did in the methods. What we did was we did use this longitudinal data. So we looked at the trends over time, and I reported the random effects results, but we also did fixed effects. And what the fixed effects does is it sort of discounts the fixed features within the patient that might correlate with even some internal behavior of, oh, I like GPs, therefore I'll go and see the same GP. So even when we did run some sort of more advanced methodological things, and the other thing we did was we ran what we call an instrumental variable, which also tries and accounts for other factors. We still found that there was some impact, we did find a difference. So I agree and that's, we just have to get this one published. So we're still working at that, but it's sort of, I think it's a higher quality piece of evidence that I would be happy to say does show an impact of continuity of care on screening. But as I said, the issue is it was 2 months, so for women who hadn't tested, they were likely to test 2 months earlier. And what is that a clinically significant effect?
And Malcolm, I think Malcolm's got a question.
Hi, thanks, Michael. That was very informative and clear. So thank you for your presentation. I'm not a GP, my background's in ethics, a little bit in health economics. And I just was thinking back to your slide from the Commonwealth Fund and reflecting on how Australia had the best health outcomes and the UK was bottom of the list, whether that had anything to do with continuity of care, because it seems to me we have good site continuity, but perhaps not such good personal continuity. And then it made me wonder about, so maybe not sharing records might not matter so much for your Australian patients, because maybe they pick and choose when they go, and they only maybe nip off to the other GP when they've got some very minor thing that perhaps doesn't have a wider bearing on their health. But as you've also been I think you're a GP here as well, I'm kind of interested. What makes you think, we're bottom of the list and you're top of the list? You got any thoughts?
Well, no, look, I do. I mean, I think, so when I was at GP originally here, I actually worked in a practice with my father. I was like this little old family practice. And so I knew all the patients, I knew all about them. And I kind of felt like I liked seeing people who I knew. And then that was great. But then I moved to the UK and worked in the NHS. And then, there was a lot of talk about continuity of care. And then I was thinking, I would see a patient, I'd potentially order some investigation on them. That investigation would go to one of my colleagues. And then my colleague would then look at the results, potentially not know exactly all the clinical information, and then ask the patient to come back to see a third colleague of mine. And, that was great continuity within a practice. But that was my feeling, is I thought, I wonder if we're losing something there. And so that's sort of what got me to look at it. But then when you do the results, looking at continuity within a practice and personal, you find that there wasn't that much difference between the two of them. Although, my clinical experience, I felt like I liked it more when I understood, when I had more control. But did that impact the quality? I don't know. Maybe we have to repeat the analysis in the UK.
Is there any attempts in Australia to improve the informational continuity side of things? Because that is one thing that I think we're getting a lot better at. So sharing records, we get really good access to hospital. I can look through into the hospital system to look at investigations that my patients are having on the hospital system, that kind of thing. Look,
it's slowly happening. I think there are I'd say now 4 different databases, 3 predominantly within general practice, but 2 that are linking to hospital data and emergency department data. So it is happening, and the Commonwealth government is investing in sort of some overarching framework. But you look at international comparisons, and Australia is kind of the least ready, one of the least technology sharing ready countries, unfortunately. But there are plans to try and improve that. And it's one of the priorities of this long-term national health plan.
Anyone else has got any more technical questions for Michael? There's my health economic colleagues. Got anything more technical that you'd like to ask? If not, I've got one further question about the 2 million increase in consultations that you've seen through COVID. Because those are all being paid for. So
50
is the health system going bankrupt?
Yeah, 50 million. No, so it's $50 million a month of, so, 25 million pounds a month of extra GP visits. Now, you'll notice that we only had 3 months of data because the Medicare data source has crashed in about July. And so we haven't been able to get data for the last 3 months. So we're not sure if that's changed, if it's improved since the pandemic. And I suppose the question is that value for money? Like, is that good that, GPs have done all that extra work while patients have been scared and had increased anxiety during the pandemic? So potentially it was a value for money initially, but is it value for money into the future once things go back to normal? And I think, you'd argue that it needs to be sustainable.
Do you have any sense of what they're planning to do about that?
Look, I don't know. Look, I think, patients are very pro it. GPs are very positive for it. Our health minister has suggested he's, keen to continue, but Treasury is not very keen. And so, there are options about, there's lots of different options. Maybe they'll link it to enrollment. Maybe they'll look at trying differential rebate. I don't know what they're, I think there's a lot of discussion amongst funders about how we could make it sustainable. And I think we'll have a better understanding if we have the longer figures. So if we see how the face-to-face and telephone has changed, but they're very anti the telephone consults. So I think, from a GP perspective, I'd say, well, they're just using, the same 15 minutes of my time, whether it's telephone or video. But the funders are saying, well, we don't really want to pay for telephone. We just want video. They haven't explained or the evidence behind that, but, we will see.
That's interesting, because that's something we've seen here, that the sort of policymakers are quite keen on video, but actually GPs, we're not using, although most of us have got access to it really quickly. We've got a really good system that links in with our record system.
Oh.
And it's actually been really easy, but actually most of the time we don't need it. Most of the time we don't use it.
Yeah, I know. And look, and I think I think the drive to the video is better, or the drive to make people do video might be different if they weren't paying by fee for service. I think if it wasn't being funded that way, potentially they'd say, look, we don't care how you do it, as long as you're providing the care that patients choose or patients need. There was someone who had a comment, I think.
Oh, yeah, Patrick.
Yeah, Michael, I'm very sorry. I've missed most of your talk for technological issues. I'm a GP in the UK and also an academic doing a PhD in continuity issues. I've also worked in Australia as a GP for 18 months, so I'm kind of well versed in both systems. And and I'm sorry if you've covered any of this in your talk, but it's merely a reflection of continuity in both countries. And my understanding of the data was that overall continuity levels, relational continuity levels in Australia are higher despite the service than we have in the UK. And it was interesting working in Australia because of the fee for service. There was, coming up there as a new GP, there was more reason to try and keep patients.
Well, we just lost you. There's more reason to keep
you, Patrick.
Oh no, it's like, what's the...
Yeah, well, Patrick's just down the road from me, so we're out in the middle of nowhere, and our internet can be...
Them up and work. There is a kind of financial incentive for continuity in Australia, which doesn't exist in the UK.
No, you just cut out there for a second. So you're just saying, yeah, there's an incentive to try and get people back. Is that what you were saying?
Yeah, there's the financial incentive for relational continuity in Australia, which just doesn't exist in the UK. And it's interesting coming back into the UK system, that people work less hours and are happy to hand patients on or have other people see them. That tends not to happen in Australia.
Yeah, you're right. You kind of tend to, yeah, you do. I mean, I do think it's easier to see people who you've seen before. And if there's a financial incentive attached to it, it probably does drive our behaviour.
Yeah.
Interesting.
Yeah,
now, while I think, please share my email if anyone wants to get in touch or send questions too.
I think Jen had another question.
Oh, yeah.
Yeah, this was going back off of what you were talking about with the current reforms and the uptake and just the increase in care really delivery. It's really great that you've been able to capture that so well, because I think GPs in both countries probably have been working hard, and it feels like we're doing a lot, but if it's not being captured in our systems, there's been ways that telephone consultations were quite invisible for a long time, and they were sort of hidden work, and now, because of the way we're doing it, we've kind of tried to bring some of that out into the open, because it's the way we're doing so much of our care that we're like, actually, all these other phone calls we used to be doing, we'll call those appointments too now. Although there's still issues in the quality of data, I think, at least on the UK side, around whether it's accurate how we're labeling those appointments or whether we're just doing. But one thing that I was wondering about is here, I think particularly you hear a lot about GP workload. GPs are sort of overworked. There's been this big increase in workload. We have a shortage. And I know you mentioned that Australia has been able to expand its GP workforce. So I was just wondering if workload isn't as much of an issue. I think whenever something new comes into GP land here, whenever there's signs that GPs are doing more work, it's all about GP workload and how GPs are already overwhelmed. And I wondered if that was part of the narrative there, or if the GPs actually had the capacity to do this extra work and it's not a problem.
Yeah, I get what you're saying, and I do remember the workload there, and I, you know, I reflect, and it is, being a GP in the UK is more difficult. You know, the speed and the quantity of work that you need to do each day is greater than what I have to do in Australia. You know, so that just the amount of illness that you're treating in primary care is greater than what happens in Australia. And so I don't know, you know, some of it'll be lifestyle, but some of it will be people have easier access to acute care services, and there's no penalties in referring people to acute services if they need, you know, so it's easy to get people into other services, because as well as having more GPs, there are probably more specialists, you know, more consultants per 100,000, you know, per head of population as well. So there are those other resources. So I think that's probably why.
I think Imelda has a question.
Hi, Michael.
Hi.
Hi. Yes, I think I'm interested in the because I went through when you mentioned about the RAC GP vision, looking at kind of general practice, the GP and general practice team being patient-centered. You mentioned earlier that the incentive in Australia is to kind of reward face-to-face kind of consultations with the GP, and there's a minimal opportunity to delegate. Whereas the case in the UK, I'm involved in a kind of project currently looking at skill mix in general practice in the UK. It's like they want to delegate everything to non-GP practitioners in general practice. Yeah. So I'm just kind of interested to know more about, you know, who are the general practice team in Australia, and then, you know, who are the non-GP practitioners really that patients can see.
So I'd say the majority of practices would have a practice nurse, you know, multiple practice nurses, and a practice manager and reception staff. But there are very few healthcare support people other than that. So you wouldn't have, there's very few other team members. Now, often you'll have allied health providers who work within a practice, but they're sort of independent contractors who tend to be co-located, but you try and involve them in the team. You know, so say like a podiatrist might rent a room, and typically that's what happens. As a podiatrist will be a private consultant, but they'll rent a room 1 or 2 days a week, or a psychologist or a speech pathologist. So they will often rent rooms within a general practice and be part of that team. GPs, a lot of GPs are co-located with pharmacies, so often but there isn't a pharmacist in the practice. It's more you use them as a resource. I mean, it's interesting. This is one of the things that, so practice nurses are probably the most embedded part of the general practice team. But the issue with this recently, the telehealth, is it then means, you know, I would think there'd be a lot of administrative calls that previously a practice nurse would have done that potentially a GP would do now, because the GP gets paid for it now, whereas they didn't before. So it'll be interesting to see what the impact of telehealth is on the workload for nurses, and whether that's changed. So, you know, I think that's one of the unintended consequences of these new telehealth item numbers, is that it may have removed some of the work that was being done by practice nurses and sort of put it back onto the GPs, which, although they're managing at the moment, might affect ongoing, you know, the capacity, and that might have the workforce implications that we were talking about before. I hope I know. That's great.
Lindsay?
Hi. Yeah, I'm just interested with regards to what you mentioned with Medicare, and in terms of how that's funded, and how patients who are in receipt of Medicare are more likely to stay within going to the same practices with regards to the payment. I'm just wondering if anything's being done with regards to the quality of care and looking at that, and whether that is impacting on the quality of care that those patients are receiving.
Some colleagues at my university have done some research looking at, do people who get bulk billed get lower quality care potentially, you know, and they didn't find any evidence to support it. Now, like I mentioned, there's limited clinical analysis that you can do, but so the evidence that we've got is that there is no clinical difference. And look, it's a question that people often raise, because they say if you go to a practice that doesn't charge you anything, you're on average are probably going to be in the room for a shorter period of time than someone who charges you more. So are you going to get worse care? Potentially those people are made to come back more often, and maybe they get the same amount of care over longer appointments. I'm not sure, but I think that's probably what you have to control for, is maybe the number of visits that they've had as well. But yeah, look, it's an area for interest. The other area that we're interested in is the increasingly there's corporate medicine, which I know there's sort of a bit in the UK, you know, so private companies who are setting up practices rather than GP-owned partnerships. And so now about 40% of GPs work in corporates, and then, you know, which are typically larger practices that are listed on the stock exchange, and there's questions about whether they've got the same motivations as a GP-owned practice. But there's been some research looking at whether you get different quality of care, and we haven't found any evidence to support that.
I think people are beginning to drop off because I think people are have other meetings and things to go to. So I think we'll probably wrap it up there if nobody's got any other pressing questions. But I'd just like to say again, thank you very much for that, Michael. It was really interesting. I think several people are going to follow up with you. I know Patrick's going to follow up with you on the continuity end of things, and I think he'd be really interested to have a chat with you. And we definitely must get you physically present in Manchester.
Yeah. No. Thanks so much. I'd love to, and I hope you all stay safe and that we get through this, and I look forward to seeing you on the other side.
Yeah, and Lindsay and I are definitely planning to come to Australia.
We need some, you need some, it's a safe place and the beach is still nice.
Yeah.
Just before everyone drops off, just a reminder that next month on the 12th of November, we will be running our next seminar, and that's Dr. Stephanie Snow. It'll be at 2 p.m. and she's looking at the crisis resilience and care and what will history make of COVID-19. So please do sign up and join us.
Thanks, everybody.
Thank you. Bye.
Bye. Oh, and